Other sources of certainly transmission would be what we call a contaminated food item, might be a foodborne or a vehicle of transmission. Those are unusual, but certainly one of the fourth modes of transmission. But the top three there are contact, droplet, and airborne. So we've got the mode of transmission, we've got the microbes on the move, as it were, and so how does it get from one resident to the next? It really has to have some way to enter the other person's body who's been exposed. So for an infectious agent that gets to a new resident or moves from one resident to the next, here's some examples of the way that would happen. You would breathe in, for example, when we talked about being close to somebody with active influenza. If you're within 3 feet, they cough and sneeze directly in your face. That would be an example of kind of the virus has moved to their respiratory tract and they've been exposed in that situation, and infection might happen. Gastrointestinal tract, obviously if we have a contaminated food item, we ingest that. That's how we would come down with kind of that type of infection. One thing we do see a lot in both acute and long-term care facilities, for an example here, would be norovirus. It does cause acute nausea, vomiting, diarrhea. That is usually a fecal-oral transmission. In other words, you've ingested the virus and it causes infection in the next person who's been exposed. Skin and mucous membrane, certainly non-intact skin. There's a break in the skin, which is probably our best barrier against exposure. If there's a break in the skin, it may be a way for the microbes or the germs to get into the skin and cause infection. Genitourinary tract, a good example, and one thing we're focusing on this study is when you put a device in a patient, it creates a way for bacteria to get into areas normally that are free of organisms. So for example, urinary tract, if we put in a urinary catheter, microbes or germs actually migrate along the catheter, get up into the patient's bladder and cause infection. And then blood, as I mentioned earlier, the contaminated lancet. If you as the healthcare worker accidentally get stuck with that lancet after it's been used on a resident, there's a potential exposure in that situation to a bloodborne virus, for example. So that's our mode of entry from really the mode, based on the mode of transmission it's gotten into the patient or the resident. And then certainly there's a lot of factors that go into our susceptibility. So I may be exposed to MRSA or have contact with a draining skin wound, not have any symptoms or even have any evidence of infection. In the long-term care facility, we've got a lot of folks who are potentially at increased risk, and those come from a variety of reasons. One of those is residents in long-term care may be very dependent on you to take care of them or help them out with activities of daily living. So that was one indication that there's a potential increased risk. Certainly immune system, so our ability to fight off infection if we do get exposed, begins to lose its effectiveness the older we get. So as we age, our ability to kind of mount a good immune response against in particular infectious agent drops considerably over time. Certainly barriers if they're compromised, so in residents in long-term care facilities, if they have very fragile skin and it gets torn, there's a barrier that's been broken which allows bacteria to get into lower structures of the skin, potentially cause infection. Urinary catheter, I made a good example there. If you put that device into a patient, likewise with a feeding tube, it's going through normal barriers that we have against coming down with or being exposed to certain bacteria that are in the environment around us. And then additional factors, certainly admission to a hospital is a risk factor for becoming colonized probably with multi-drug resistant organisms. So in acute care side in the hospital, we have as many multi-drug resistant organisms as you do see in long-term care facilities. One of the key distinctions is in acute care facilities, we have a lot of devices we put in patients. So very high proportion of patients gets an intravenous catheter put into them. We use a lot of urinary catheters, much more so than a long-term care facility. And we may do surgery where we actually cut the skin. So all those put you at increased risk of exposure. So when they come back to your long-term care facility, they may either be colonized, in many cases, with a new organism that they picked up in the hospital, or because of the susceptibility of this resident has become colonized with other bacteria or germs. Certainly the last one there, antibiotic use. Very important to be very careful about who gets antibiotics, especially in healthcare facilities, long-term and acute care. What happens is the antibiotic actually suppresses some of that endogenous flora, what I call the friendly microbes that are there on each of us all the time. That helps prevent infection with some of these more unusual strains. When people are put on antibiotics, it suppresses their normal kind of microbial flora and allows for some of these multi-drug resistant organisms to show up. So that certainly is a risk factor for that resident. So how do we break this chain? I think the key thing is all of you are infection preventionists. So we're elated that you're participating in this study because it's very important to, you are the advocates and the folks that are protecting your residents who are under your care. And all of us have a very important role in infection prevention. So your facility may have an infection control coordinator or an infection preventionist who leads the program. We really depend on you that take direct care of your residents to interrupt and break this chain of transmission. The other key piece about this chain of transmission is just because I can culture Staph aureus from a bed rail, for example, or MRSA, doesn't mean it's going to cause infection automatically. We have to complete all these chains and this loop of transmission before we have a risk of actual introduction of infection.